Chapter 11 and Chapter 12 and ATIs, Chapter 17 through 22, talk about postpartum care and care for postpartum complications, which is things you'll need to know as labor and delivery and women's health nurses. So during postpartum care, which is immediately after the infant is born, your education to your patient is going to continue. So you're going to have been already and continue to teach self-care, good hand washing. You're going to show your patients how to do perineal care, wiping front to back, bladder training, so as soon as she can feel her legs, if she's had an epidural, to get up and try to use the bathroom. Breastfeeding help. Most of the time, we'll put babies skin to skin immediately. That helps with temperature regulation, with blood sugar regulation, with breastfeeding. And then you always want to educate your patients about safety, using the call bell and asking for help those first few times that she gets out of bed. So immediately postpartum, the vital sign protocols can vary. The general rule is you're going to do Q15-minute vital signs and fundal checks for the first 2 hours on your patient, on mom. Temperature, you want to be less than 100.4 Fahrenheit. The pulse, you want it to be between 60 and 80, respirations between 60 to 20, and for blood pressure, you're going to compare to her baseline. It could be increased because of oxytocin use, but you also want to be aware that you can have postpartum preeclampsia, and you want to assess any significant variations or changes from your baseline blood pressure. So again, your nursing care for this postpartum period is assessing mom, intervening if there's anything you need to intervene with, and educating her on what to expect. So an easy way to remember your postpartum assessment is bubbles. You might see bubble he or bubble heal online. For our purposes, we're going to use bubbles. And that just is an acronym to help you remember of your focused assessment, which is breast, uterus, bladder, bowel, lochia, that bleeding after birth, any episiotomy, any edema, her emotional state, and then section is just if she's had a cesarean section. So things that would make you want to investigate is if there's heavy bleeding, any type of foul-smelling discharge, which could mean an infection, or elevated temperature, persistent abdominal pain, which could mean endometritis or an infection, severe cramping. So all of these are not really normal. Calf pain, breast pain. So calf pain, you're thinking possibly DVT. Breast pain, she could have mastitis, which is a breastfeeding complication or breast complication. And then persistent sadness, despair, anxiety. You're thinking, there's postpartum blues, but with this you're thinking if it persists, more so into the postpartum depression range. So any of these things, if you're walking into your room or you're talking to a woman postpartum, these are signs that you want to investigate further. So for breasts, we'll just start at the top. The first 2 days postpartum, they should be soft to the touch, colostrum, that first milk should be present. By the 3rd day, the breasts are starting to fill. They should be firm and warm, but they shouldn't be engorged. They shouldn't be hard to the touch. For your breast assessment, you're looking at tone. So are they soft? Are they filling? Are they firm? What's the nipple condition? So are the nipples intact? Are they reddened or cracked or bleeding? Blood blisters, which would make you think there's some issue with breastfeeding or the baby's latch. And then you're assessing the type of nipple. So are they everted? Are they inverted? Are they flat? And then you want to just go into the room knowing if mom had any breast surgeries. For breast augmentation, you can still breastfeed. It depends on the type of surgery she had, and it depends on her wishes if she wants to continue to use if she wants to continue to breastfeed or wants to breastfeed after breast augmentation, but there's no reason that she can't if that's her choice. So again, when you're doing your breast assessment, you're assessing for comfort, you're educating her on any breastfeeding or formula feeding needs, and you're looking for signs of mastitis. Most of the time, mastitis will be seen later on, like the 3rd or 4th day. It is an infection or an inflammation of the breast, but you can see that, if a woman is saying in the hospital postpartum longer than that third or fourth day. So it is something that you need to be aware of, and it is something that you need to be aware of if you go into women's health nursing in general, because you could possibly work at a clinic or, an OBGYN office. So again, what we're looking for is to make sure that everything is happening as we expect it to. So a complication is, again, mastitis. Usually it doesn't occur until several weeks after childbirth. Axillary lymph nodes are large, they're warm, tender, and there's a hardened area on the affected breast. So inflammation is the cause. Sometimes it's an infection. Usually it's unilateral, so usually just one side. Bacteria can enter a milk duct through a crack in the nipple, so that's why if a mom already has cracked nipples or bleeding nipples, you really want to educate her on washing her hands, on patting them dry, maybe even using some colostrum for pain control, and for also to help clear up that nipple. Engorgement and incomplete breast emptying may contribute and make symptoms worse. So you really want to educate mom to try to put the baby on. We say 8 to 12 times in a 24-hour period, which works out to be about every 2 to 3 hours. But it doesn't have to be regular like that. And it may progress to an abscess if it's not treated. So you want to be assessing for this when you're postpartum, and also when you're women's health and you're in the clinic and you're seeing women that are coming in postpartum. So subjective signs that your patient might feel are fever, chills, pain or tenderness, aches, fatigue, a general feeling of malaise. The objective assessment is, her temperature is going to be higher. You might feel warmth at the infection site. Her nipples might be cracked. You might see fissures or sores. And you might have drainage from the nipple or have some redness on that affected side. So for nursing care, you're going to treat with antibiotics, application of heat or cold for comfort, sometimes analgesics, hydration, and, obviously the best bet is to prevent. So you want to educate women on frequently feeding the baby, alternating breasts, washing her hands, frequently changing breast pads, allowing nipples to air dry, proper positioning and latch techniques, so really trying to get that infant on, the whole areola, and so she's not more prone to sort of blisters or cracks in her nipples. And then you want to try to get her to completely empty her breast to prevent milk stasis, which can also be a precursor or a risk factor for mastitis. So moving on to the U, so uterus is going to return to its pre-pregnant state. So if you remember from the first module, pre-pregnancy, the uterus is about the size of your fist. It grows to be about 20 times that size during pregnancy. So then there's a process called involution after birth, where it backs down and goes back down to its original size and back into the pelvis down here. So within a few minutes after birth, it's firmly contracted, and it can be palpated halfway between the umbilicus and the symphysis pubis. So, about right here. Approximately 1 hour after birth, it rises to the level of the umbilicus and remains there for the first 24 hours. So, you have a patient that's 24 hours postpartum, you're expecting to feel that top of the uterus or that fundus right here about at the belly button. And you want it to be firm and you want it to be midline. And then each day, it'll descend about 1 centimeter or 2, or a finger breadth or 2. And then again, by about 10 days, that uterus is back down into the pelvis. So when you're assessing the fundus, you're assessing the level, the location, and the tone. So again, it should be midline, so in the middle. It should be firm. It shouldn't be tender. If it's not midline, so if it's off to the right, you want to check to see if mom has a full bladder, because a full bladder could displace it. So that would be your first, very least invasive intervention. If you check a mom and her fundus is boggy or not firm, or if it's a little bit to the right, it's not midline, you want to offer her assistance to the restroom and see if emptying that bladder doesn't help that uterus to firm up and get back down, or get back into the middle. So what you're seeing above is the fundus is firm, midline, and at the umbilicus. So that's what you're expecting in general at 24 hours postpartum. And you want to always just support with this bottom hand down here when you're doing your assessment. So A complication of the uterus is postpartum hemorrhage. So when you think about postpartum hemorrhage, you want to think of the 4 T's. So most of the time the causes are tone, so atony, the uterus not having much tone, trauma, any kind of cervical or vaginal lacerations, tissue, so retained placental fragments can cause a late hemorrhage, and then thrombin, so any issues with maternal coagulation. So atony, again, is most of the time, about 80% of the time, that's the cause of a postpartum hemorrhage. So what you're going to assess, what you're going to feel, is a uterus that's boggy. It's not firm, or it's hard to find. She's going to be bleeding. You might see big clots. For trauma, so that we're thinking is more cervical or vaginal laceration. So when you assess a mom that's bleeding, or you're finding blood, that uterus is going to be firm, but there's going to be a steady trickle of bright red blood. So if you check your mom, you check her fundus, the fundus is firm, it's at you, but there's steady trickle of bright red blood, then that should sort of relay to you, she's bleeding, but that bleeding is coming from somewhere else. It's not uterine bleeding. And then tissue, again, retained placental fragments. So the provider is going to examine the placenta at birth to make sure that none of those cotyledons are left, or no fragments of the placenta and the placenta membranes are left inside, because again, that can cause a hemorrhage later on. And then, thrombin, so any issues with mom's coagulation, that can also be a reason that she's hemorrhaging postpartum. So these are reasons that you might see it. Again, atony, or that loss of uterine tone, is most often what you're going to see, but you do want to know the difference in, why a postpartum hemorrhage can happen. So nursing care, if you have a boggy uterus, or a uterus that's not firm, one of the first things you're going to do is massage that uterus. You're going to encourage mom to void, and you're going to diligently assess her in those first hours after birth. So massaging that uterus really helps those uterine arteries to contract. It helps that blood flow to sort of, helps there to not be too much blood flow, helps that uterus to get back down to size in the time frame that it should. Nursing care for trauma, so again, you assess your mom, you assess your patient, that fundus is firm, but she's bleeding and it's bright red, then you're going to notify the provider, because that could mean that she needs a cervical or vaginal repair, or a repair in her perineum somewhere. So risk factors, most of the time, again, they're related to uterine atony. So anything that can overstretch that uterus out. So overdistension, such as twins, triplets. Hydramnios is just lots of amniotic fluid. So if she's gestational diabetic, or there seems to be a lot of fluid for another reason, that can be a risk factor for postpartum hemorrhage. Macrosomia is just a big baby, so a bigger baby can stretch out that uterus. Dysfunctional labor patterns are a risk factor if she's had a postpartum hemorrhage before. Using oxytocin, even though we use that to clamp the uterus postpartum, and we use it for an induction and augmentation, sometimes a longer labor, I think evidence has shown after about 19 hours of labor, augmentation with oxytocin, you're at higher risk for postpartum hemorrhage, because your body just stops listening to those receptors. So labor induction with oxytocin puts you at higher risk for postpartum hemorrhage. And then use of medications that promote uterine relaxation. So we talked about magnesium sulfate, or we will talk about it in preterm labor, nifedipine in trying to stop preterm labor. Those moms are going to be at a higher risk for postpartum hemorrhage, and that's going to be something that you want to watch out for them. And then there's reasons related to trauma. So if you have a rapid second stage, so you're not pushing for very long, if mom has a really precipitous labor, so from beginning of contractions to when the baby's born is very fast. Operative deliveries put you at a risk for postpartum hemorrhage related to trauma. If a provider uses forceps or a vacuum, and then C-section patients are also at higher risk for postpartum hemorrhage. So these are the risk factors. There's more, but you're going to want to be aware of, what puts a woman at risk for postpartum hemorrhage, and then what am I going to do if I see one. So there's also early hemorrhage and late. So an early or primary occurs within those first 24 hours, most likely within those 4 hours postpartum. So that's why we're checking our moms. We're checking our patients, Q15 minute vital signs, Q15 minute fundal checks for the first 2 hours, because statistically that's when the hemorrhage is going to occur. There can be a late hemorrhage, so that's called a secondary hemorrhage, and that's anywhere from 24 hours to 12 weeks. Again, retain placental tissue, so the body's not getting the message to clamp down and get rid of that tissue. Infection, and that's manifested by cramping and passage of large clots and bleeding that's just not stopping. So when you educate your women when they go home, if they're saturating a pad in less than 15 minutes, even if they're at home and if they've been home for 2 or 3 weeks, that's something that they want to call their provider about. So the definition, according to the American College of Obstetricians and Gynecologists, so ACOG, of a hemorrhage is a cumulative blood loss of greater than or equal to 1,000 mLs, or blood loss accompanied by signs or symptoms of hypovolemia within 24 hours after the birth process. We learn about postpartum hemorrhage because it remains a leading cause of maternal morbidity and mortality in the U.S. and worldwide. So hemorrhage that leads to blood transfusion is the leading cause of severe maternal morbidity in the U.S. So not only, are women dying, or they can die because of a postpartum hemorrhage, but in our country, a hemorrhage that leads to a blood transfusion is the leading cause of high severe maternal morbidity. Morbidity meaning, adverse effects. So not necessarily your patient is dying, but there's an adverse effect because of the birth. So something's happening after birth that wasn't supposed to happen or that wasn't expected. So for postpartum hemorrhage, you're going to want to know the medications that we use. So one of the first things that we will have on board is oxytocin. Again, it's an one of the first things that we're going to have on board for postpartum hemorrhage is oxytocin. So that stimulates uterine smooth muscle and produces contractions. So it's similar to the contractions that you have during spontaneous labor. You're going to give 10 units IM if you don't have any IV access, 10 to 40 units IV in 500 to 1,000 mLs of IV fluid, such as lactated ringers or normal saline. So there are contraindications that you want to know about. And again, it's a first-line treatment for postpartum hemorrhage due to uterine atony. And again, most of the time, once that anterior shoulder is delivered or once the placenta comes out, oxytocin postpartum is going to be started. A bag of oxytocin is going to be started prophylactically. So it's not, that's called active management. So especially in a small community hospital, you're not going to wait for the hemorrhage to start. You're going to have that medicine on board. You're going to be actively managing it, hoping that you can control that bleeding postpartum so you don't get to the point where you have a hemorrhaging patient. It can cause hypotension and cardiac arrhythmias. It can cause water intoxication, so you're going to do strict I's and O's on your moms or on your patients. And again, because it's clamping that uterus and it's stimulating uterine smooth muscle contractions, it can be painful. It can feel like contractions or like cramps when a woman has that, so you want to educate her on that. Methyljonavine maleate is Methergin. You're going to want to know the generic name. It's an ergot alkaloid that causes uterine contractions by stimulating uterine and vascular smooth muscles. So this is given IM. If you have a woman that has a history of hypertension or preeclampsia or currently has an elevated blood pressure, that's a contraindication for Methergin. So you want to know those contraindications when you're thinking about these medicines. Considerations also are it needs to be refrigerated, needs to be covered. So what you need to know is Methergin is given IM. You're not going to give it to anyone that has a history of hypertension or preeclampsia because of the severe vasoconstriction, and it needs to be refrigerated. And again, in the order that these medicines are given, depend on the protocol, depend on the provider preference. Carbapenem, tromethamine, or Hemabate is also given. It's a prostaglandin analog. It again stimulates contractions of that myometrium. You're going to give 0.25 milligrams or 250 micrograms IM. You are not going to give that to a woman that has asthma, any kind of renal disease, cardiac disease, and you're not going to administer if the patient is demonstrating shock, because it will not be well absorbed. Again, this needs to be refrigerated. It's an expensive medication, so when we're talking about, throughout the world, what we're using for postpartum hemorrhage, you have to think about the costs as well when you're looking at public health as a whole. So, methotrexate maleate IM, 0.1 to 0.2 milligrams IM, Q2 to 4 hours, depending on the provider. You're not going to give that to women that have a history of hypertension, gestational hypertension, preeclampsia, and carbapenem, trimethamine, brand name Hemabate. You are going to give 0.25 milligrams or 250 micrograms IM. You're not going to give that to women who are asthmatic. This also causes, because of the stimulating the contractions of the myometrium, it also can cause contractions of the carbapenem is also something, if you give women, that will cause diarrhea postpartum. So sometimes when you get the order for carbapenem, you'll see that there's an order for carbapenem can also cause diarrhea in your patients, so sometimes you'll see orders that have to do with that. It's something that you want to educate your women on. But again, in an emergency situation, you're going to use what you can to get that uterus to contract. But it is a side effect that you want to be aware of and you want your patients to be aware of. Misoprostol or Cytotec is a prostaglandin analog, helps to contract those uterine muscles. It's actually used for stomach ulcers, so using it in labor and using it for early termination or early abortion, or using it to induce labor, are all off-label uses for this. For postpartum hemorrhage, you're going to give a very different dose than you would give for an induction or for an abortion. So you're going to give 800 to 1,000 micrograms rectally, or you can give it sublingually as well if your patient is awake. So oxytocin, methergin, carbapenem, misoprostol, these are the 4 that you're going to see most likely, and these are the 4 that you're going to know for this course, that you're going to need to know for this course. So for bladder, so we're going on down, so B-U-B. So breast, uterus, bladder. In our bubbles, we're encouraging our patients to void within 2 to 4 hours if they have feeling in their feet and everywhere. Kidneys are going to eliminate 2,000 to 3,000 milliliters of extracellular fluid with a normal pregnancy. There's UTI risk factors, so if your patient have had a lot of catheterizations, a lot of straight casts, frequent exams, epidurals, any kind of perineal injury, history of UTI, C-sections, all of those women are at higher risk for UTIs, so you want to educate them on keeping their bladder empty, on signs and symptoms, on washing their hands. And then hemorrhage risk factors, overdistension can lead to an increase in bleeding, and the uterus can't contract effectively. So again, when we check our fundus, or the top of our uterus, and it's displaced because of a full bladder, that woman is at higher risk for hemorrhaging, because that uterus can't contract effectively if the bladder is sort of overdistended and kind of moving up into the top of the uterus. So you want to educate women, void within 2 to 4 hours, do bladder training, try to get up every time you feed the baby, try to drink a glass of water yourself, try to go to the bathroom yourself, but you can ask for help every time. Nursing care, you're going to assess for signs of infection, dysuria, any kind of urinary frequency, urgency, retention, low-grade fever, and you want to, again, encourage voiding to decrease the hemorrhage risk and decrease risk of UTI and any issues with the bladder postpartum. Endometritis is an infection. It's a uterine infection that you're assessing for postpartum. Risk factors are cesarean birth, prolonged labor, rupture of membranes, again, multiple vaginal exams, operative delivery, poor postpartum care. So you really want to be careful in teaching your patients to use hand hygiene, using her dermoplast or using her spray bottle, wiping front to back, just sort of patting to dry. Your assessment on this patient, if there was a possible infection such as endometritis, would be at a temperature above 101. Her uterus would be very tender. It would be larger than expected for postpartum day, which is called subinvolution, and you would have foul-smelling lochia. So remember, if we talked about on the first slide, your uterus is supposed to be, at you on the first day and go down 1 to 2 centimeters each day, or 1 to 2 finger breaths, so you're day 2 and you're thinking, okay, this uterus should be, 2 centimeters below the umbilicus, and that uterus is higher than expected, and it didn't start out higher as expected, so you have to look at your trends. Or, you're helping her change her pads and there's a foul-smelling lochia, because lochia is made up of, red and white blood cells, lining of the uterus. There is going to be sort of a, earthy or bloody smell, but it shouldn't be foul-smelling. That's indicative of an infection. So you would collect cultures if they were ordered, administer IV antibiotics and analgesics for any pain, and a big part of this is just maintaining maternal-newborn bonding, because this is a mom that really doesn't feel well. So she has a temperature, her uterus or her fundus is, hurting, it's more painful than it should be, it's larger than expected, so she's just in general uncomfortable and not feeling well. So you want to make sure that you do everything you can to maintain that maternal-newborn bonding, and that you administer those medications and those pain medications as prescribed. So for bowel, relaxin and progesterone lower bowel motility, so it tends to be sluggish. Constipation can happen postpartum and also during pregnancy. Nursing cares, you're going to assess for bowel sounds, you're going to ask about passing gas and bowel movements. A lot of women are afraid or are fearful of having a bowel movement postpartum, but you want to educate them. A lot of water, a lot of fruits and vegetables, getting up and moving around will help those bowel movements to be softer. Sometimes there are stool softeners ordered, so you want to educate them and encourage, again, ambulation, hydration, high fiber, and use of any ordered stool softeners. Hemorrhoids can also be something that you might see postpartum, and you can just educate women on, again, maintaining perinatal care and care of the bottom, using your peri bottle, and then usually Tux pads or witch hazel pads are ordered, and that can relieve any discomfort. So lochia is classified as scant, light, moderate, or heavy. It's quantified by weighing the pads. Again, that's that bleeding that you're going to have for about 6 weeks or so postpartum. For the first 3 days or so, you're going to have lochia rubra, which is that dark red bleeding. Lochia serosa is more pinkish, that lasts about 3 to 10 days. And then lochia alba is white, and that lasts about 10 to 14 days. You want to know the difference, you want to know these words. For nursing care, you're going to assess for foul smell, you're going to assess for saturating pads in less than 15 minutes, presence of large clots, or extreme pain. So some bleeding, some clots, some discomfort, all normal, but a foul-smelling bleeding, saturating a pad, like fully saturating pad with heavy bleeding in less than 15 minutes, large clots, or having extreme pain postpartum, those are all things that need to be assessed and are variations of normal. So that's not what you're expecting when you walk in the room. And most of postpartum assessment and labor and delivery assessment and newborn assessment and really assessment in nursing is just knowing when you walk in the room, okay, what do I expect to see? Where am I postpartum? What day is this? What am I expecting? And then what do I see? And then if there's a difference in what I'm expecting and what I'm seeing, how do I intervene? And then when I intervene, did my intervention help? Or do I need to do something else? That's really all nursing is, and all nursing school is if what I'm seeing, is what I'm seeing normal? If not, what do I do about it? Then I intervene. Did my intervention help? Do I need to do something else about it? So for our E's, I just put episiotomy, edema, and emotions all in one, just to help you remember at that E. So now we're at the end of bubbles. We're at the E right before the S. So episiotomy is a purposeful cut in the perineum by a provider. You are going to assess that. You're going to visually inspect the vulva, the perineum, the rectum for any kind of lacerations, hematomas, hemorrhoids. So this is a midline episiotomy, and this is a mediolateral incision. Women can also have tears, natural tears that occur naturally, and they can be repaired, or they can just be left to heal on their own, depending on the degree of the tear. Most of the time, nowadays, I don't really see these purposeful incisions, because studies have shown that letting a woman tear and repairing that tear is easier or is better for recovery time. And they've found that, sometimes when you do an episiotomy, then you're more apt to tear, and then the tear is a larger grade than it would have been if you had just let your patient tear naturally. So edema and extremities, you're going to assess edema, location, grade, and again, lower edema in the feet, normal, edema in the face and hands, not as normal. You're thinking, maybe issues with blood pressure or preeclampsia, especially if it's new onset. You're going to assess for any pain in her legs, any warmth, any redness. You're going to assess pedal pulses for sensation. And again, you're thinking, is there DVT? Is there any kind of, anesthesia complications? So if you're assessing a mom, 4 hours postpartum and she can't feel her feet, then you want to call that anesthesiologist and let them know that. It all depends on when you're assessing, what you're expecting to see. And then emotions, you're generally assessing mom's overview, and you're using nursing judgment. And we'll talk about postpartum blues, depression, and psychosis. And this is not a question you're going to ask mom. This is subjective. So you're not going to say, how you doing emotionally? What do you think about that baby? You're just going to kind of assess in general what she talks about, what she asks about. Is she holding baby? Does she feel comfortable? And then you're just going to have an open dialogue so you can help her with anything that she needs assistance with. So episiotomy complications, episiotomy and complications. Episiotomies can extend. They can become a 3rd or 4th degree laceration. Lacerations, again, can be in the cervix, in the vagina, around the vulva, the perineum, or the rectum. They're manifested more so by continuous trickling of bright red blood. And again, when you assess that fundus, the uterus is going to be firm. So these lacerations are repaired by a provider. A hematoma, you might see that's a collection of blood within the tissues. You might see a bulging bluish mass. Your patient's going to have pain more so than normal on her bottom. It's going to be persistent. And, you might not see noticeable bleeding. You might just see, differences in her vital signs and that persistent perineal pain. It just depends on the situation. So for nursing care, you're going to assess vital signs and hemodynamic status. You're going to educate women on pain relief, so ice for the first 24 hours. You're going to educate them on using a warm sitz bath after 24 hours. So ice for the first 24, warm sitz bath after 24. Dermaplast is a topical anesthetic that sort of numbs and cools the perineum. Witch hazel and glycerin pads can be used for the perineum, and again also for hemorrhoids. And then usually NSAIDs could be used for any kind of bottom pain relief, and they also, because of their anti-inflammatory properties, really can help with postpartum cramps. Because those contractions don't necessarily end. Again, baby's born, placenta comes out, that uterus still needs to clamp down so those uterine arteries can close up, get back down to normal. So that's going to be a couple days, maybe a couple weeks of some postpartum cramping. So you want to educate mom on infection prevention, using her peri bottle, changing her pads often, wiping front to back, and just patting dry, especially if she has stitches. The stitches most of the time will dissolve, so you want to educate her. You might see a stitch on a pad, that's okay, as long as you're not continuously bleeding. But usually there's no, she doesn't have to come in and have a separate procedure. She's just those stitches are gonna dissolve while she's healing. So as a nurse, you are going to want to contact the provider for any laceration repairs and any signs of hematoma that you're seeing clinically. Again, persistent perineal pain, a bulging mass, or any issues with her vital signs. So this just shows you the lacerations are measured in degrees. And again, these aren't something that you're going to need to know or need to memorize, but you're going to need to understand, a 1st degree is only really that perineal skin. Sometimes that'll be repaired with stitches. Sometimes it'll be left to heal depending on how far it goes into the skin. The 2nd degree, the skin and the muscle of the perineum, and it could extend into the vagina. These are going to be repaired. 3rd and 4th degree repairs, they're going to extend into the muscle that surrounds the anal sphincter, and then a 4th degree is going to extend through the anal sphincter and into the rectal mucosa. So these women are going to have extensive repairs. They're going to have ice. They're going to have medication ordered. They're going to have, sitz bath after that first 24 hours. They're going to have, a little bit. They're going to have a little bit of a, more extensive repair and repair time, and you're just going to want to know that when you're assessing mom and when you're seeing, how she's progressing through her postpartum healing. So again, it's not like you have to understand, it's not like you have to memorize, what's 1st, what's 2nd, what's for 3rd, what's 4th, but you have to understand, as the degrees get higher, she has more extensive damage, more extensive repair, and her healing time might change, and her need for medication and education might be greater. So this is just a visual of a hematoma, what you might see. So it's a collection of blood within the tissues. Again, persistent perineal pain rather than noticeable bleeding. Any clinical signs, any changing in the hemoglobin or hematocrit, any kind of signs that you're seeing that mom is losing blood, even though it maybe isn't necessarily sort of visual or visible. For edema and extremities, you're assessing the location, the grade. For extremities, you're assessing, is there any pain in your patient's legs, any warmth, any redness? And again, we're hoping the answer is no, right? But women are at higher risk for deep vein and superficial thrombosis because of those increased clotting factors. Again, your blood volume is 40 to 50% higher when you're pregnant. You have increased clotting factors. You have pressure of the uterus on your lower extremities. You have maybe trauma from childbirth. So you're at higher risk for thrombophlebitis because of all of these things. So you want to be aware of any complications or any signs that anything is happening. And obviously, if she's like, yes, I do have pain, you want to contact your provider so you can rule out anything more detrimental like a DVT. For emotions, you want to know about postpartum blues, depression, and psychosis. So postpartum blues, 50 to 80% of women get it. It resolves within 10 to 14 days. What you might see is that they're tearful, there's mood swings, they're anxious, they're fatigued, they're sad, they can't sleep, they forget. There's a lot of hormonal changes happening postpartum. Many women get this. Many women sort of get very sort of weepy on the 2nd day. That's when the baby's really kind of wanting to eat and waking up. And mom's exhausted, especially if she's had a long induction or if she had a traumatic birth. So you sort of have to realize it is fairly common to be weepy or to be kind of sad in those first few weeks or so. It becomes postpartum depression if it extends beyond those baby blues. So when you're getting out to like day 10, day 14, and you have a depressed mood every day, you can't sleep, you're not really washing yourself or washing the baby, you're thinking, negatively, you're just feeling hopeless. That's more so postpartum depression. 10 to 20% of women get that. It occurs within 6 to 12 months. So, it doesn't have to sort of start right at, day 14, but it's any kind of depression that happens within that first year that lasts beyond 2 weeks. So if you're thinking, the difference between postpartum blues, depression, and psychosis, postpartum blues, it resolves by about 10 to 14 days postpartum. Postpartum depression is, anytime after that, if she's depressed for at least 2 weeks and having these signs and symptoms, they're going to look at postpartum depression. And there is a medication now that you can, that providers can offer women for postpartum depression, and we'll talk a little bit about that in class. Postpartum psychosis is rare, so very common for blues, not as common for postpartum depression, very rare for postpartum psychosis. That's a rare, again, mental illness. It's 0.25 to 0.6 per 1,000 live births. So rare, but it does happen. You need to be aware of it. It occurs within the first 6 months, most often between days 3 and 6 postpartum. And these are where your patients are getting hallucinations, delusions, they're increasingly agitated, confused, suicidal or homicidal. They're not taking care of the baby, they're just losing touch with reality. So you want to educate women on, each of these. You want to educate women on the commonality of blues and depression, and you want to educate them, if you get to the point where you're hallucinating, you're hearing voices, you're thinking thoughts, you really want to call 911, and you want to educate their partners about these as well. So for your nursing care, you're assessing their general emotional well-being from admission. You're seeing how it is, what's the vibe in the room, how is your patient doing, how's the family, everything that's happening. And then you're sort of just making mental notes of any complications. There is something called the Edinburgh postnatal scale. Many times women will get that throughout their pregnancy at prenatal visits, and then there's also a scale that you can give them at discharge, and you want to educate them, you can always call the labor and delivery floor. They're open 24 hours. They might not have, mental health support there, but, a nurse can always offer themselves because, 9 times out of 10, when you're going to have these thoughts or when you're sort of breaking down, it's going to be 2 a.m. on a Saturday night. It's not going to be, Monday morning at 10 when you can call your doctor. So I always like just to offer women, our patients, you can always call the labor and delivery floor if you have questions, if you're wondering if something's normal, if you're having any kind of thoughts. And then as nurses, it's our job to be able to give women resources so they can get the help that they need. So risk factors are prior history of postpartum depression, any history of depression or bipolar, any family history of mood disorders. You can imagine if you've experienced stressful events during the past year or any kind of complications with the pregnancy or birth, that you might be at higher risk for postpartum depression. If you have 2 or more babies, if the babies were premature, if they're unplanned, unwanted, any kind of issues with feeding. These are all stressors. So these are all things that put women at higher risk for postpartum depression. And again, there's a sharp drop in those estrogen and progesterone levels right after birth. So, for a few weeks, her body is sort of regulating those hormones. And all of those things put together put women at higher risk for postpartum depression. What you're going to do to intervene is there's going to be the screening with the questionnaire, most of the time in the hospital, and then again, also prenatally. You're going to provide care and reassurance. You're going to educate her to call the provider as soon as possible if she has any of these symptoms. So it's been 2 weeks, it's not getting better. The symptoms are getting worse. It's getting harder to take care of myself. It's getting harder to take care of the baby. I can't clean the house. I can't really do anything. I'm having thoughts of harming myself or the baby. Those are reasons she wants to call her provider or call 911 so they can find a plan and look into how they can best support her for the rest of her postpartum journey. And then there's also local and national resources, so you don't have to be Jewish. Jewish Family Services is open to all. That's in our state. And then there's also Postpartum Support International. These provide 24-hour text and calling assistance. So again, if it's 2 o'clock in the morning on a Saturday night, she doesn't want to call the hospital, or, the nurse wants to give her some information after she's called the hospital, she can call this 1-800 number and get support for postpartum depression 24 hours a day, 7 days a week, via telephone call or just texting. And that is available in English and in Spanish. So to recap, when you're thinking bubbles for your postpartum assessment, you're looking at breasts, you're looking at the uterus, you're looking at the bladder, the bowel, the lochia, episiotomy, emotions, edema, and then section if you've had a C-section patient. And how you would assess a C-section patient is you would do it however you would do any kind of wound. So, a Rita or cage socks. You're making sure there's no drainage, there's no fever, there's no smell, there's not any kind of redness or pain. So when you're doing your postpartum assessment, the biggest things are you want to walk in your room and you want to know, okay, what am I expecting? What day postpartum is she? Is she breastfeeding? Is she bottle feeding? What do I expect to see when I walk in there? And then if I'm seeing something that I don't expect, what complication is happening? What can I do for her? Do I need to get the provider involved? What can I offer her? How can I make this better? So when you're doing your postpartum assessment, you're always thinking, what am I expecting to see when I walk in the room? And then if I have complications, how can I intervene to help her